Good morning, everyone, and welcome to the Neuroblastoma Australia Family Conference. And I'm delighted to be here to introduce the first session. This meeting is part of an ongoing partnership with the International Global Symposium, which is happening over the next 2 days, and I'll be presenting at additional sessions there, and I invite you to join that meeting as well. My name's Daniel Morgenstern. I'm a pediatric oncologist at the Hospital for Sick Children in Toronto, over here in Canada. Delighted to be able to join you through the wonders of technology all the way across the world. My role is as a solid tumor oncologist, and I co-lead our neuroblastoma program, and also have an interest in early phase drug trials and in therapeutic mIBG. So I'm just going to now share my slides and provide an introduction to this meeting and really kind of discuss the question of what is neuroblastoma and to provide you with some background to this topic. So I think, first of all, it's useful to start by considering the name of this cancer and what we're dealing with. And I think everyone knows the name neuroblastoma. Most people who've never heard of this disease automatically assume that it's a brain tumor because of the word neuro. And neuro is in there because, as we'll talk about in a minute, this tumor does come from primitive nerve cells, but these are not nerve cells that are in the brain. They're nerve cells that are outside the brain in the body and typically part of the what's called the sympathetic nervous system. Then there's this strange word blastoma, and I've just put up on the left-hand side here the names of a number of different types of childhood cancers that you'll see all have very similar names: neuroblastoma, retinoblastoma, hepatoblastoma, and nephroblastoma. And this is no coincidence. This phrase blastoma really has a meaning in and of itself. A blast is the name of a primitive cell that really doesn't look like a mature cell under the microscope. And as you can see in the picture down on the bottom left, if you look at a neuroblastoma or these other blastoma tumors under the microscope, typically what you see is what's called small round blue cells, which are cells that are small, round, and blue. And often this is how these tumors are described. And the relevance of that is really that these are tumors that are undifferentiated, which means that the cells that make up these tumors don't look like normal mature cells. And this is really in contrast to the adult cancers, for instance, breast, lung, prostate, and bowel, which are the most common cancers in adults, which are very different. These are carcinomas, and that means that they are fundamentally different when you look at them down the microscope, that they look like cells that are derived from the particular organs. So I think the most important message from this is neuroblastoma has the word neuro in it, but it's not a brain tumor. It comes from nerves in the peripheral nervous system. But there is this tumor called a blastoma, and that is a very common type of tumor in children, which involves primitive cells forming a tumor, and that's really what the oma part of the name means. So where does neuroblastoma come from? And as I've already mentioned, it arises from the sympathetic nervous system. So this is a part of your nervous system that runs up and down the side of the spine, and you can see that on the picture on the right in yellow. And it also includes the adrenal glands, which are little glands that sit on top of the kidneys. And you've got two of these, one on each side. And the purpose of this part of the nervous system really is to help with what's called flight or fight responses. So essentially, if you become stressed or anxious, this system produces hormones like adrenaline, or called epinephrine on this side of the pond, and those then help to stimulate the body. And some reason neuroblastoma arises from these nervous cells somewhere during development. As we'll talk about in a minute, we kind of got some sense of where the tumor comes from, but we don't really understand how it arises. But the important thing from this picture is that, as you can see, although the adrenal glands are sat on top of each kidneys, and those obviously down in the abdomen, the kidneys are set right at the back, the sympathetic nervous chain, this thing in yellow on the picture, stretches all the way up and down the spine, all the way through the chest, up into the neck, and all the way down into the pelvis. And this is important because it means that neuroblastoma tumors can occur anywhere along that chain. So some patients have a tumor that appears in their abdomen. That's the most common site. But equally, there are patients who have a tumor that appears for the first time in the neck, and it's because of this distribution of the nerves that these tumors arise from. So how does neuroblastoma present? I don't want to go into this in great detail because I'm sure many of you are familiar with this, and you all know the difficult story of how your own child presented. But I just wanted to highlight a few things. So most commonly, neuroblastoma presents with a lump that somehow somebody notices, either a lump in the neck or a lump in the abdomen that's either picked up on a scan, or a parent or somebody else feels that lump. Children can often be kind of generally unwell, and as we'll talk about in a minute, neuroblastoma can often spread to other parts of the body, and so that can cause pain. And it may be that children present with a pain in their bones or a limp or something like that as the first presentation. Young babies can have an unusual pattern of neuroblastoma where they can have little clusters of neuroblastoma cells appearing under the skin, and can have little skin nodules, as we can see in this picture on the right-hand side. There's a very important type of presentation of neuroblastoma where it can affect the orbit, so the bones around the eye, and then it can lead to bruising around both eyes. And that's well recognized as a, not a very common, but an important way in which neuroblastoma presents. And then on the bottom of this, right of this picture, I just wanted to highlight this issue of spinal cord compression, because one of the questions that we're often asked for parents who have children diagnosed with neuroblastoma is, could we have picked this up earlier? Would it have made a difference if we picked this up earlier? And as I'll talk about in a minute, the treatment for neuroblastoma is very complicated, but actually, on the whole, it normally does not make a difference whether the tumor has been picked up early or after a delay of a few weeks or a few months. The one exception to that, and I think the important exception to that, is patients who have a tumor that is pushing on the spinal cord. And the purpose of this picture here really is to show a tumor which is close to the spine and then pushing on the spinal cord, which is the nerves that run up and down inside the spine. And in those cases, the function of the spine in terms of sending signals for movement or for pain or for bladder control can be really very badly affected by the tumor. And those are cases that really need treating very quickly. But for the vast majority of patients, either with a localized tumor or with high-risk disease, it probably doesn't make a huge difference whether it's picked up on day one or whether there's a delay of a few weeks or even months in picking it up, because ultimately the treatment that tumor requires, the outcome for that tumor, is likely to be determined by the underlying biology, by the genes that are abnormal inside that tumor. So then, just in terms of terminology, we've talked about what neuroblastoma is, that it's a tumor, so it's an abnormal growth, an oma of primitive cells, blast cells that have arisen from a nerve origin, so neuroblastoma. But what makes neuroblastoma a cancer? And essentially the hallmark of a cancer is that the cells that are dividing rapidly in an abnormal way have the ability to spread elsewhere in the body. And really it's that ability to spread elsewhere in the body that defines something as a cancer. And neuroblastoma quite commonly spreads to elsewhere in the body. About half of patients that we see on day one will have neuroblastoma that's spread elsewhere in the body. And I'm just showing here an mIBG scan on the left-hand side and a picture of a bone marrow on the middle, showing pictures of neuroblastoma spread essentially into the bone or into the bone marrow, which are the most common sites. It is possible for neuroblastoma to spread elsewhere in the body, but other sites, especially those at the bottom of this list, like the brain and lungs, are much, much less common. So in terms of the question of who gets neuroblastoma, I think really the answer is that we don't actually know what the true worldwide incidence of neuroblastoma is, because actually the vast majority of children who get neuroblastoma are likely to be in sub-Saharan Africa, South America, China, where we don't have good numbers. But I've just put on here typical numbers of patients of around 800 a year in North America, a similar number in Europe. And obviously the Australian population quite a lot smaller, and so about 40 cases a year is the typical number for Australia. On the right-hand side, I'm showing a graph of how common neuroblastoma is according to age. And the most important message here is that really this is a disease primarily of young children. And actually the younger you are, the more common neuroblastoma is. And the vast majority of patients who are diagnosed with neuroblastoma are very young, under the age of 1 year. There are older patients who are diagnosed for the first time with neuroblastoma, but those are much, much less common. So then I want to kind of put neuroblastoma into context. I think obviously all of us in this meeting know about childhood cancers and know about neuroblastoma, but it's important to realize why what we're dealing with is a niche indication, is a rare thing that most people have not heard of. And what I'm just putting on these charts here on the left-hand side is to compare all childhood cancers, so that's that red bar, all cancers in children, against the most common adult cancers. And you can see that childhood cancer is really incredibly rare when compared to adult cancers. And then if we break down those childhood cancers into different types, neuroblastoma is, we like to say, the most common solid tumor that is not in the brain, but it's certainly not the majority of cases of cancer in children. And as I said, about 40 cases a year in Australia, about half of those will have high-risk disease. So that's 20 cases a year, and even a smaller number might have specific genetic changes or might need specialist treatment for relapse disease. So this is why it's critical that there's international collaboration, and most of the trials that we do for neuroblastoma involve two big international groups called the Children's Oncology Group, which is based in the US, or SIOPEN, which is based out of Europe. And I think you'll hear more about those during the rest of this meeting. So I think we all know that neuroblastoma and childhood cancers are very important, and they're a major impact on children and a major cause of death, sadly, in children. But I think it's important that we continue to advocate for that, because compared to the sheer numbers of adults that are diagnosed with cancer, we are a very small subset. So one of the other very common questions that we get asked about neuroblastoma, especially from families where there's a new diagnosis, is why did this happen? Why did my child get neuroblastoma? And I wish I had a good answer, but fundamentally we don't know. And I think the honest answer for the vast majority of families when there's been a new diagnosis of neuroblastoma is we just don't know why this has happened. There's been a lot of research done about, could this be due to an exposure to something in the environment? Could it be something that mothers have been exposed to during pregnancy, fathers have been exposed to? But at the moment, there's really no convincing data of anything in the environment that triggers neuroblastoma. This slide is very complicated, but I just wanted to kind of use it to make a couple of points, which is that I think if you think about embryological development, if you think about essentially how you make a baby, you start with a very small number of cells. You start with one cell, and then it divides and divides and divides and divides and divides to get millions and millions and millions of cells. So that's cell proliferation. And then quite a lot of the time during the putting together of an embryo, those cells have to migrate. They have to move from one part of the body to another in order to go and turn into a new structure, a new organ. And I just want to highlight that, because actually those two things, which are growth, proliferation, multiplication of cells, and movement of cells around the body, are exactly the same processes as go on to cause cancer. Those are the things that cancer cells do, which is that they divide very rapidly and they can spread elsewhere in the body. So I think, simplistically, the way to think about neuroblastoma and other childhood cancers is that it's to do with something having gone wrong during development of the baby, when it's been first put together as a fetus, as an embryo. We don't know exactly when that first abnormality occurs, but if you think about putting together an adrenal gland, you've got to start with a very tiny number of cells, and then they've got to multiply up to form the gland. And if there then is not a signal to tell the cells to stop growing, they will just continue on growing and growing and growing and growing and growing. And you can imagine that was how you then end up with a neuroblastoma tumor. So it obviously doesn't actually tell us what has ultimately gone wrong to trigger the formation of that tumor. But I think it's a really useful way to think about childhood cancers, because this is a fundamentally different process than that which causes adult cancers, causes lung cancer or bowel cancer. We're not talking about children who've been exposed to lots of toxins in the environment, who've been exposed to cigarette smoke or have had bad diets. We're not talking about cells that have been exposed to things that damage them. It must be something intrinsic, something inside those cells that has somehow gone wrong. And so that leads to this question of, well, what is it inside those cells that has gone wrong? And to some extent, it must be to do with the genes that are in those cells, the genes that control what those cells do. And again, a complicated figure, but I don't want to go through the details, but it's just to say there's been a lot of work done looking at what genes might drive neuroblastoma in a particular patient. And what this graph is designed to show is that we found a very small number of genes that are shown in the top left, which have a very strong effect on triggering neuroblastoma, but are incredibly rare. So there's these gene abnormalities in genes called ALK and FOX2B, just the names of the genes, where in very rare families, there's a parent, a grandparent who had neuroblastoma or a similar tumor, and we can follow a particular gene abnormality in or in FOX2B down to the new patient who then also had neuroblastoma. But it's important to emphasize that is very, very rare. So it's not the majority of patients. And in the majority of patients, the neuroblastoma occurs in a sporadic way, which means it occurs, but we don't understand what the underlying genetic change is. On the right-hand side of this graph, I'm just putting the list of the names of a bunch of different genes where we found that there are abnormalities in these genes, sometimes just not even abnormalities, but common variations that are associated with a very, very slight increased risk of neuroblastoma. But we don't really know how to use that information, and we don't really understand at the moment exactly what those variations in those genes are doing. So there's a lot of work still to be done here to answer this question of why do children get neuroblastoma. But I think the most important thing is to take away the message that somehow it's to do with something that has changed, gone wrong, programming during development, but it's not. To say this is bad luck, and I wish we had a better answer to this question. Sorry for the background pinging. So the next really important thing to emphasize is that not all neuroblastoma is the same. We have one word for neuroblastoma, but actually that encompasses a huge, huge variety of behaviors, of presentations, and of need for treatment within that one name. And I'm going to talk about this in a little bit more detail, but this graph is just to highlight the different outcomes. These are historical data, so they're a little bit out of date now, between different subsets of patients with neuroblastoma. And the important thing from this graph is that if I show you in green or in blue patients with low risk or intermediate risk neuroblastoma, the vast majority of those patients have a very good what's called event-free survival, which means they don't have an event, which means they don't have a relapse, they don't have progression. So the vast majority of these patients, about 90% or so, are cured and the disease never comes back. And unfortunately for those patients with high-risk neuroblastoma, you can see that the curve drops down quite steeply, and that's because unfortunately a significant proportion of those patients do have a relapse, do have disease that comes back, and we're still really trying to find better treatments for those patients. So the difference between these is obviously huge, and that's why it then becomes really important to think through for any individual neuroblastoma case, what treatment does the individual patient need? How am I going to what's called risk stratify this patient to work out the right amount of treatment for this patient? So the risk stratification for neuroblastoma is actually incredibly complicated and keeps changing as we learn more about the disease. But I think the simple way to think about it is really that we divide patients into those who have high-risk disease and those who don't have high-risk disease. And I think most of the discussion in this meeting and the global meeting that's to come will really focus on patients with high-risk disease, because those are the ones that we are really looking for new treatment strategies to try and improve outcome. Because at the moment we use very intensive, very complex therapy, and unfortunately we're still not able to cure all of those children. But the other half of patients with non-high-risk disease have a very broad range of outcomes as well. Generally, they need much, much less treatment, but actually what is complicated often is working out exactly how much treatment any individual patients need. Some need no treatment at all, and we can observe the tumor and it will get better on its own. Some need surgery to remove the tumor, and some need chemotherapy. And as I say, the risk stratification, the things that we take into account to make these decisions are very complicated, but the most important ones are the age of the patient. Generally, younger patients under the age of a year, under the age of 18 months, have a better outcome than older patients with neuroblastoma. The stage, which means is the neuroblastoma in one place in the body or has it spread elsewhere in the body? And as I say, about half of patients, the disease has spread when we first see it. And then critically, the biology. So what is it in that individual tumor that is driving that tumor? Is it destined to behave aggressively, or is it destined to behave in a non-aggressive way? And I think, what's extra complicated about neuroblastoma is that there are likely to be quite a lot of patients out there that we never even know about, who had small neuroblastomas that appeared in the adrenal gland, were never known about, never caused any symptoms, and went away on their own. And so this is another area that we just don't really understand about neuroblastoma, is why is there such a difference in behavior between the non-high-risk neuroblastomas that are localized, potentially small, resolve on their own, versus the high-risk patients. And I think we're gradually learning more about that, and many of you probably would have heard the name of this gene mIBG, which is very important in determining how the neuroblastoma behaves. And gradually we're learning more and more about the ways of identifying these different groups of patients. So just to talk a little bit more about high-risk neuroblastoma. So these are generally patients who either have this what's called mIBG amplification, so a particular gene change in their tumor, or where the neuroblastoma has spread to other parts of the body, which is called metastatic disease or stage 4 disease. And as many of you, I'm sure, will know, we have a very complicated treatment for this high-risk neuroblastoma. And we're gradually building on the treatment that we've developed over the years to try and make it better and better, because unfortunately there are still patients for whom that treatment doesn't work. And by not working, I mean either the disease does not respond properly at the beginning, or it responds and then unfortunately it comes back again. And so these graphs here are really to just show, if we look back to the early 1990s, that as we've gone through the 30-year period since then, we have managed to improve the outcomes for these patients over time. So we are making progress, but clearly there's still a long way to go, because we are unfortunately not able at the moment to cure every patient with high-risk neuroblastoma. I spoke already about risk stratification and the importance of separating out high-risk neuroblastoma from non-high-risk neuroblastoma. But actually, increasingly, we're learning that not all patients with high-risk neuroblastoma are the same. So actually, one of the most important factors that determines how well a patient will do is how the disease responds to treatment. And we only know that once we've started treatment. But also, even within this group of patients who have high-risk disease, we know that there are factors that affect outcome. So older patients tend, unfortunately, to have a more difficult time in terms of us controlling the neuroblastoma. And patients with disease that has spread, it's harder for us to completely eradicate it than those where the tumor is still localized in one place. And so one of the things that I think is coming in the next generation of treatments for neuroblastoma, for high-risk neuroblastoma, is for us to begin to try and separate out these different groups within high-risk neuroblastoma, so that they're not all getting exactly the same treatment, but in the future at least, we can begin to fine-tune the treatment to these individual risk groups within this broader umbrella of high-risk neuroblastoma. Another point that I think is really important, I'll just briefly mention it then, which is to say that what really matters is how well the disease responds to treatment. Is that because of that, it means that the risk for one individual patient, their likelihood of cure, their likely outcome changes over time. Because at the start of treatment, we don't know, is this tumor going to respond, which the vast majority do, or is unfortunately not going to respond. And so that means that actually, as patients go through treatment, through the complicated treatment for high-risk neuroblastoma, if the disease responds as we want it to, the chances of a successful outcome improves over time. And so this is very important to, to think about for families and clinicians, because the information that you get at the beginning when you're having a new diagnosis chat, a discussion about, well, what are the outcomes for patients with high-risk neuroblastoma, and unfortunately discussions that a significant number of patients will have disease that comes back. Those numbers change over time for individual patients. So if you get through induction chemotherapy, get through high-dose chemotherapy, get through immunotherapy with no sign of the disease getting worse and a good response for the tumor, actually the likely outcomes then are much, much better than they were at the beginning. And this is really important for anyone who's reading the literature and going to read papers, is that generally the outcomes that are reported in papers that are published are not talking about all patients with neuroblastoma. They're talking about patients receiving a specific type of treatment. And so for studies that are asking a specific question about a specific part of treatment, the point when they start the clock may be different. So some papers will talk about all patients from the point of diagnosis, but other papers will only start the clock for patients, for instance, who are starting to get immunotherapy. And those patients who are starting later on, if the analysis starts later on, will always have a better outcome, because the patients who unfortunately did not respond to the early part of the treatment won't be included. So I hope I've managed to get that across, because it's really important if you're looking at papers with outcome data, that outcome information may or may not be relevant to the to the individual case, to your individual child. I'm not going to talk in great detail about the current treatment for high-risk neuroblastoma, because I think there's another session that's going to cover this, but I just wanted to highlight that although there are lots of different cooperative groups around the world, including SIOPEN in Europe that I've mentioned, Children's Oncology Group in North America, other groups in Japan and elsewhere, the overall strategy for treating high-risk neuroblastoma is broadly the same, which is to use multiple different kinds of chemotherapy drugs at the beginning in induction chemotherapy, to resect the primary tumor, to consolidate the response with high-dose chemotherapy, which is in blue here, and then to give radiotherapy treatment, and then to give a maintenance with antibody anti-GD2 immunotherapy. So the details of this are different between different studies and different cooperative groups, but the overall strategy is very similar across these major cooperative groups. Another really important question is this one of, well, why is neuroblastoma so difficult to cure? I've just, very briefly in 2 seconds given an overview of the very, very intensive, complicated, difficult treatment that we use for high-risk neuroblastoma. Why is it that with all of that treatment, we're still not able to cure the disease? And I'm trying to get some of that across on this chart. So this is a figure counting the number of cancer cells up on this side against time. So when the tumor first appears, there's maybe 1, 2 cancer cells. We can't detect it at that point. And it grows rapidly, and the graph goes up here, up until the point where there are millions and millions and millions of cancer cells, and enough cancer cells for us to see a lump. And that's when we first are able to diagnose the patient, because they have something that we can detect. Then we start treatment, maybe surgery in some cases, maybe starting with chemotherapy for most patients with neuroblastoma. And so we're gradually able to bring down the number of cancer cells. So we kill a bunch of cancer cells with the chemotherapy. We have to give a pause between chemotherapy to allow the body to recover when maybe some of those cancer cells regrow. Then we give more chemotherapy and so on. And we're gradually able to drive the number of cancer cells down. And we may well get to a point where the number of cancer cells is so low that we can no longer see them on our scan. So we can't see a lump on a CT scan. We can't see any cells in a bone marrow test. We can't see any spots on an mIBG scan. But the problem is that when we get to that point, we still probably have some cancer cells left in the body, because we can't at the moment detect down to the level of the individual cancer cell hiding out anywhere in the body. And so even at the point when the scans get to become negative, clear, it's likely that there are still cancer cells left in the body. And it only takes a few of them, honestly, we don't actually know how many it would take, but a few of them to still be left for to escape from treatment, for the tumor then to be able to regrow once we stop treatment. And so the challenge is that in order to cure neuroblastoma and to cure other cancers, we've got to get to the point where we've essentially eradicated, one way or the other, all of the cancer cells. And that's very difficult to do, as you can imagine, to get rid of absolutely every cell. And the further challenge is that we've not really at the moment any way of assessing patients in this point of the graph. So once the scans are clear, but where we think there are still cancer cells there. But this is one of the reasons why we give treatments like immunotherapy, even when the scans are clear, which is that we believe that there are still cancer cells that are floating around or hiding out somewhere that we need to get rid of with the immunotherapy. And ultimately, by giving further treatment to try and drive those numbers of cancer cells down even further, we can hopefully get to the point where we eliminate them completely. And I think one of the future developments that is likely to come is better tests, genetic tests, maybe genetic blood tests that allow us to detect very, very low numbers of cancer cells. And maybe we can then discover some additional treatments that will help us to push those number of cancer cells down even further, even beyond the point where we can see anything on scans. So I'm coming towards the conclusion, and I just want to float a few of the big unanswered questions in neuroblastoma. And I'm going to highlight these, and unfortunately, at the risk of causing frustration, not actually be able to answer any of them for you, but just these are some of the topics that I think are most pressing. We still don't really know the answer to the question of what causes neuroblastoma. Why does it occur in the first place? And I think that is, an important question to answer. And there's a lot of work going on to try and answer that. There's still a fundamental challenge of patients with high-risk disease whose disease does not respond to initial treatment, so they have refractory disease, or it does respond and then the disease comes back, so they have relapse. How can we cure those patients? What are the new treatments that we can use? How can we change our current treatment to make it better? Are there new drugs? Are there new types of treatment that we can use? And there's a lot of research going on that, and you'll hear more about that in this meeting and the global meeting. A really important topic that I've just not mentioned is that the treatments that we're using at the moment are very complicated, very intensive, and really quite toxic to children. And we know that they can have acute side effects at the time when we're giving them, but we're also learning that they can have significant long-term effects as well. So for instance, hearing impairment is a major side effect, unfortunately, of a lot of the treatments we use. So what can we do to prevent that in the future? At the moment, it's really difficult because we're still trying to improve outcomes, but at some point, we're going to need to try and find a way of challenging ourselves to improve these late effects as well. As I've already mentioned, is there a way that we could fine-tune treatment for patients with high-risk neuroblastoma? At the moment, most patients with high-risk neuroblastoma are treated in the same way with that overall strategy that I showed. But in the future, maybe there are ways of us selecting out patients who have got high-risk disease but are going to do a bit better. We need slightly less treatment. Maybe there are some novel treatments that we can add in to patients with high-risk disease where we think that they're not going to respond to our current therapies. And then perhaps a final question, are there other treatments that we could add to our neuroblastoma therapy to try and prevent relapse? And at the moment, we just don't know the answer to that question. So, an important set of questions. I think we'll get some answers to those from the other presentations that are being given in these next few days, but a lot of work still to be done. So finally, I just want to end with a few take-home messages. Crucially, every child with neuroblastoma is different. As I've tried to highlight, neuroblastoma is one word, but actually for a huge variety of conditions. And even if we take patients with high-risk neuroblastoma, they still have significant differences between them. And even if we took a group of patients with very similar neuroblastoma, the actual experience of those individual patients and their families is going to be very different. So, these meetings are useful, but a lot of what you hear will need filtering through for something that might or might not be relevant for your individual child or for an individual child. And so it's really important, ultimately, when making treatment decisions that we take into account the individual patient that we're looking after. Point 2 here kind of goes without saying, but I think I'm going to say it anyway, which is a lot of this is extremely complicated and it keeps changing over time. So our understanding of neuroblastoma is constantly changing and evolving. And so often there actually isn't a right answer. There's just our best answer at this time, and it's gradually evolving as we learn more. And then a final message is, please ask lots of questions. For those of us presenting in these meetings, it's really most helpful if we can hear questions from the audience, because then that lets us ensure that we're actually answering the things that you want to know about. So I'd really encourage you to ask as many questions. And if the technology works, hopefully I'll be able to join you live in a second or two, and I'd be very happy to answer any questions that you have at that point. So I'm going to finish there and stop talking. I hope that was a very useful overview. I hope the rest of this meeting is useful, and I encourage you to join the global meeting that this Australia meeting is part of. Many thanks.